Hey guys, and welcome to Unit 8, Part 6. In these last 3 video note sections, we're going to be going over the treatment of abnormal psychological disorders. So first, we're going to go into some of the history behind it. And when people in the past have displayed unusual behavior, sometimes people were locked up or even used really strange matters. And one of the ways was getting rid of evil spirits was either one, beating people out of, like beating them out, bleeding them out. Trepanation is where you would put holes in people's head to let the spirits release. And clearly we do not do that anymore. But this is how a long time ago people thought this is how you treat people with a strange behavior. This chair was designed to be an improvement in medical treatment. It was supposed to give a calming effect to people. We started to look at people as insane instead of possessed, treating them with tenderness or kindly, housing them in hospitals versus locked up in asylums, and starting to look at psychotherapeutic treatments, medications, and community support. Current forms: psychotherapy, interactive experience with trained professionals, understanding the changing behavior, the way of thinking, relationships, and emotion. Biomedical therapy is the use of medications that act right on the body to help with the symptoms of mental disorders. An eclectic approach uses techniques from various forms that kind of fit the patient, so it could be very individualized. They can be used together to help achieve a better reduction in symptoms. So with some of our schools of psychotherapy, with psychoanalysis, Sigmund Freud, it's still carried on today. Psychodynamic therapy, looking at our past, our unconscious. With Carl Rogers and Abraham Maslow, with the humanistic approach, client-centered. It's all about the client, what's going on there. Behavioral therapy, using conditioning. And if you guys remember in the past, with B.F. Skinner and Ivan Pavlov, with both operant and classical conditioning. And then cognitive therapy, changing our thoughts. Aaron Beck and Albert Ellis, reducing errors and distress, changing our thinking patterns. A little more, with Sigmund Freud, sometimes our symptoms were repressed conflicts, to his belief, and he came up with 2 techniques. Free association, the patient just talks freely about memories, dreams, feelings, whatever comes to mind. And then interpretation, the therapist would suggest unconscious meanings to kind of give the patient insight and calmness to be like, oh, well, if you're dreaming about this, it means X, Y, Z. The therapist might see unconscious meanings in resistance, dreams, and transference. Resistance, the therapist notices times when the patient seems blocked in speaking about certain subjects. So in the dream, there might be themes or latent content behind the plot of a patient's dream, and latent content is just what you learn afterwards. And then transference, the patient may have reactions towards the therapist that are actually based on feelings towards someone from the past. Psychodynamic therapy, less intensive version, fewer sessions, focuses on improved self-awareness and looking at changing patterns and thinking There's interpersonal therapy, which is a little bit beyond psychoanalysis. It's less focused on the insight, but more on behavior change and symptom relief. And it focuses more on current relationships and feelings versus focusing on the past. Humanistic psychology, with Maslow and Rogers, emphasizes human potential for growth, fulfillment, self-actualization. With the humanistic therapy, looks to get support with personal growth, with self-awareness and self-acceptance. Client-centered therapy is Rogers' name for his style of humanistic therapy. The goal was to promote growth, take responsibility for feelings and actions. The role of the therapist was to provide an environment where that growth could happen. And they wanted to actually focus on the self and what the ideal self would look like, and would focus on the present and future versus the past. Being non-directive, let insight and goals come from the client. Let them be truthful and be yourself when you're talking to your patient. Being accepting and showing unconditional positive regard, and being empathetic, paying attention to your client. Behavior therapy, the client might know that they need to make a certain change, but find that it's hard to actually change that behavior. So they can use classical and operant conditioning to help reduce unwanted responses. And this is a treatment used to help addictions or negative emotions such as panic. Counter conditioning refers to linking new positive responses. So if you've been conditioned to fear stores because you had panic attacks there, you could be led into a store and then helped with relaxation exercises. So then you can associate stores and relaxation. Exposure therapy. A conditioned fear can worsen when you avoid it. And thinking that there can be quick reduction in anxiety. So you're like, oh, okay, I'm not there, I'm good. But guided exposure to the feared situation can reverse this. They can get used to the anxiety and then that feared situation. Other exposure therapy, systematic desensitization. You are slowly exposed to your feared thing. So if it's heights or flying or spiders, and then you keep increasing that level of exposure until you can tolerate it, and then you increase it again. And it makes it so that you can overcome or get used to or manage your fear. Virtual reality therapy. This involves being exposed to simulations, like flying, like the one below, or snakes. People say bedwetting can be a form of operant conditioning. Because there's punishment for wetting the bed. Assuming the child is not wetting on purpose, the bed wetting is not an operant behavior, and the child cannot choose to avoid the alarm. The association that is made is a biological state, a full bladder and relaxed bladder, and sudden alarming wakefulness. So this is more linked with classical conditioning. Aversive conditioning, when a person has been conditioned to have a positive association with a drug. So in this example, you have the drug cause nauseousness. So you have alcohol plus the drug, and it gives nauseousness. So then anytime they see the alcohol, they get nauseous. So if we're trying to get an alcoholic to stop drinking, this could be effective. Operant conditioning refers to shaping behavior into the desired response you want. Behavior modification talks about shaping a client's chosen behavior to be a more desired behavior. We see this a lot. Again, with token economies in schools, you see it more often in elementary schools, uses coins, stars, Seahawk bucks or whatever that can be collected and traded in for reward later. There are some critiques though. Does it work? And when it does it stick? And we do find that it does often work, especially in the lower ages. Is it ethical? Is it wrong to change people's actions without consent? There's consent of guardians, parents, and goals. So if the person is talked to about, hey, look, we don't like this behavior, let's see if we can change it, we can move on. Hope you guys have a great day.